From super serum fantasy to regenerative medicine. Many of us know the fictional idea of super soldier serum, one injection that creates extraordinary muscle power. But our proposal asks a safer biomedical question. What if one injection could help a severely damaged muscle recover lost function? This is the idea behind our injectable mRNA lipid nanoparticle hydrogel for volumetric muscle loss, or VML. Volumetric muscle loss is a large loss of skeletal muscle that exceeds the body's natural capacity for repair. It can happen after severe trauma, tumor resection, military injury, or major surgery. It is not a simple strain. VML removes muscle fibers, extracellular matrix, blood vessels, nerves, and the satellite cell niche that normally drives regeneration. When that microenvironment collapses, the body fills the defect with fibrosis and scar instead of organized, contractile muscle. So the core problem is not an empty space. It is a missing regenerative environment. This matters because current care can improve coverage and appearance, but full functional recovery is still difficult. A flap or graft may close the defect, and rehabilitation may improve movement. Yet the patient can still remain with weakness, limited range of motion, and long-term disability. That is why our central endpoint is not muscle volume, but functional force recovery. Tissue that looks like muscle but cannot contract has not solved the problem. And that makes VML a true medical engineering challenge. Previous approaches each solve part of the problem. Free muscle transfer and flaps restore coverage. Rehabilitation improves limb use. ECM scaffolds add structure. Cells and growth factors add biological cues. But if we map them by what they address, two axes emerge: structural versus biological support, and single signal versus multiple coordinated signals. Every existing option clusters in one corner. The region that combines a local platform with multiple, coordinated regeneration signals over time is empty. That white space is exactly where our platform is positioned. So our goal reframes the fantasy serum into a realistic therapy. We will develop an injectable, local, temporary, and controlled mRNA lipid nanoparticle hydrogel that converts a fibrotic VML defect into a regenerative microenvironment. 3 words define it: local, so it acts only at the defect; temporary, so the signal fades after the job is done; and controlled, through a designed release window. By keeping the signal local and transient, we reduce the risk of systemic or uncontrolled effects. The platform has 3 components, each with one job. The hydrogel is a local scaffold and sustained release depot. It occupies the defect, supports cell migration, and slows cargo diffusion. The lipid nanoparticle, or LNP, protects the mRNA and carries it into local cells. The mRNA itself is a temporary instruction to express regenerative proteins. Because mRNA does not edit the genome, the expression is transient and controllable. That is exactly what we want for safe, localized tissue repair. Rather than betting on one magic molecule, we propose a modular cargo strategy that targets key bottlenecks in regeneration. IGF-1 mRNA supports myogenesis and muscle repair. VEGF-A mRNA supports vascularization, because new muscle needs blood supply. IL-10 mRNA supports immune modulation and anti-fibrosis, because prolonged inflammation drives scarring. These are candidate cargoes, not a fixed recipe. We will screen them and select the best single lead, or a staged combination. Innervation will be evaluated as a functional integration outcome, and supported through scaffold design or rehabilitation-based alternatives. This way, the platform adapts to the biology instead of depending on one uncertain mechanism. To see why this platform is differentiated, compare the approaches across 5 criteria: local delivery, multi-signal action, transient and safe expression, tunable release, and translational potential. Surgery, rehabilitation, scaffolds, cells, and growth factors each satisfy only some of these. Our mRNA lipid nanoparticle hydrogel is designed to combine these features in one local platform. That integration is the main reason we propose it as a next-generation strategy for VML repair. The work is organized into 3 specific aims. Aim 1 engineers the injectable hydrogel depot, optimizing injectability, gelation, stiffness, degradation, and release kinetics against defined engineering targets. Aim 2 optimizes local mRNA lipid nanoparticle delivery and cargo selection. It tests uptake, expression level and duration, and biological response in muscle, vascular, and immune assays. AIM-3 validates regeneration in a rat tibialis anterior VML model, comparing untreated injury, blank hydrogel, empty LNP hydrogel, and the therapeutic mRNA lipid nanoparticle hydrogel. In this way, we test material, delivery, and biology step by step. Success is measured at 3 levels. At the platform level, injectability, mechanics, degradation, release, local expression, and biodistribution. At the tissue level, muscle fiber regeneration, fibrosis reduction, vascularization, and innervation. And at the functional level, the level that matters most, contractile force recovery. This will be measured by in situ contractility testing through sciatic nerve stimulation, plus movement-related outcomes. Engineering targets anchor the early work. Gelation under 5 minutes, degradation over 2 to 4 weeks, and LNP size around 80 to 120 nanometers. The plan runs over 5 years with explicit decision gates. In year 1, we optimize the material and screen cargoes in vitro. In year 2, we test retention, expression, and early regeneration in vivo. In year 3, we focus on functional force recovery and safety. Years 4 and 5 are for scale-up and translational optimization. At the end of each of the first 3 years, there is a go, no-go gate. So the project advances only when the prior milestone is met. This keeps the program disciplined and de-risked. We do not hide the risks. We anticipate them, and each has a pre-planned plan B if regenerated tissue is weak or poorly innervated. We tune hydrogel stiffness, add aligned or nerve-guiding microstructure, or combine the treatment with rehabilitation. If vascularization is insufficient, we prioritize VEGF-A or provascular cues. If fibrosis persists, we use an IL-10 cargo or a more ECM mimetic gel. If expression is too short or not local enough, we tune LNP dose, degradation, and release. And to limit off-target effects, the injection stays local and dose-controlled. Mapping risks by likelihood and impact shows that the most serious ones already have concrete mitigations. The ethical boundary must be explicit and non-negotiable. This platform is not proposed for elective enhancement in healthy people, and it is not a doping strategy. It is a therapeutic restoration platform for damaged muscle. Local injection reduces, but does not eliminate, systemic risk. So we will keep our claims careful until the work is tested. The super soldier idea stays only as a hook. Everything after it is therapeutic restoration of lost function. If successful, this project could shift VML treatment from reconstruction toward true regeneration. Instead of only closing the defect, the goal is to create a local environment that supports muscle formation, blood vessel growth, nerve integration, and force recovery. And because the platform is modular, the same injectable system could be adapted to other localized tissue injuries simply by changing the mRNA cargo. The goal is not stronger than normal humans. It is giving patients with devastating muscle loss a controlled path back to movement. Thank you.